It's not only one measure that protects the spinal cord ischemia, but it's a complete panel of measurements that you have to keep in mind when treating this patient. So, good morning, everybody. My name is Daniela Branzan. I'm a professor at the Technical University of Munich, Germany, and I'm the head of the clinic and polyclinic for vascular and endovascular surgery at the TUM University Hospital. I was invited at the Critical Issues 2026 by Professor Eric Verhoeven to talk about one of my favorite topics, spinal cord ischemia, and he asked me to concentrate on the measurement that still really works, or that really works in protecting the patients of receiving a spinal cord ischemia after endovascular repair of extensive thoracoabdominal aortic pathology. We all know that spinal cord ischemia is a devastating complication that affects survival and also quality of life after extensive thoracoabdominal aortic repair, and its percentage can get up to 20% in the extensive aortic diseases. Of course, our goal is to reduce this percentage, and in order to do that, we have to know what causes the spinal cord ischemia. Basically, we have very important patient risk factors such as the length of the aortic coverage, hypertension, hypovolemia, renal insufficiency, but also procedure factors that affect these results, such as urgent or emergent cases and the length of the aortic coverage. Very important is when to treat this patient, and maybe we have time, a part of urgent procedure, to have in mind a full protocol of the protecting the spinal cord ischemia. When I say that, we have to look at the permissive hypertension. We have to prepare this patient by reducing the antihypertensive medication. During the procedure time, we have to have a mean arterial pressure higher than 90 millimeter Hg. We have to have a good oxygenation of the patient blood. Besides these preparation methods, we also have to very well prepare the procedure. And when to prepare the procedure, we have to keep in mind how the spinal cord is perfused. Basically, we have a spinal cord collateral network that has been introduced a long time ago by Professor Grip. And in order to have a good perfusion of the spinal cord after the end procedure, we have to stimulate this spinal cord network before using stage procedure. There are different ways to stage your endovascular procedures, such as you perform a first stenting of the thoracic aorta before your fenestrated and branched endograft. You can leave a shunt branch or a extensive limb open before the thoracoabdominal procedure, or you can perform the well-known procedure MISACE that I have been talking about a long time ago, and has been shown to have great results in our cohort before performing the procedure. After staging the procedure, after the first stage of the procedure, you can perform the final procedure about approximately 7 days to exclude the thoracoabdominal aneurysm. Also, during this procedure, it's very important to respect the permissive hypertension in order to reduce the spinal cord ischemia. As you can see here, it's not only one measure that protects the spinal cord ischemia, but it's a complete panel of measurements that you have to keep in mind when treating this patient. And I want to recapitalize. You have to have a permissive hypertension, you have to stay the procedure, and you have to monitor very well the person also after the procedure on ICU at least for 48 hours. Of course, when you have this devastating complication, you can also have some rescue procedures such as implantation cerebrospinal fluid drainage in order to reduce the intra-compartment pressure in the spinal cord. And of course, you can do that also before the procedure, but I do not recommend it due to high complication risks. So basically, you have to characterize your patient from the beginning on. You have to have a perioperative, intraoperative, and a postoperative strategy, and you have to plan your procedure as a staged the treatment. I think, in my opinion, the risk of spinal cord ischemia can decrease up to maximum 5% in very complex cases.